Hello, everyone, and welcome to our webinar. We are in the midst of our RayCare webinar series. This is number 2 today. My name is Dana Bodensteiner. I am the Director of Product Management for RaySearch Americas, and I have the honor of moderating today's webinar and introducing our speaker, Dustin Simonson. Dustin received his PhD in Radiation Health Sciences from the Johns Hopkins University. He's an ABR certified physicist in therapeutic radiologic physics and an ACR ROPA accredited surveyor since 2014. Currently, Dustin is Chief of Medical Physics at Frederik Health Cancer Institute in Frederick, Maryland, where they are one of our first RayCare users in the United States. And he will share with us some of his experiences to include their CyberKnife planning and RayStation. Dustin did this similar presentation at our users meeting last December. It had rave reviews, so therefore we've asked him for an encore in hopes of reaching a larger audience. But before I turn it over to Dustin, I'll share a small world story. I think I met Dustin about 3 years ago, but this past fall, when he was getting ready to present at the RayStation users meeting, he happened to look at my LinkedIn profile and realized I was from South Dakota. It turns out we graduated the same year from 2 different high schools in Rapid City, South Dakota. So it's very fun for us to have that South Dakota connection. And with that, Dustin, I'll go ahead and turn it over to you.
Sounds good. Thanks, Dana. So yes, it was fun to be in Miami at the last users meeting, and there's actually another South Dakotan that was there, another RaySearch employee, Misty. So it really was quite a treat to have 3 South Dakotans outside of the Midwest, which is akin to seeing like a herd of unicorns running down the highway. It's not something you see very often. So yeah, so I'll be talking about our experiences with RayStation RayCare, and I'm going to be focusing on the rationale as to why we made this decision to go with the RayStation and RayCare platform. So if you're not a CyberKnife user, fear not. There's a lot of this talk that will be applicable to you, and I think it's kind of some of the rationale that I think will be most useful to a number of the viewers. So I don't have any conflicts of interest to disclose. I do want to say right off the bat that my background here, I've been at Frederik Health for 20 odd years. So we're a community cancer center. And I'll talk a little bit about us a little later on. But I did want to say that my experiences are going to be based on implementing this in a community cancer center. And that can be a very different type of environment than the larger commercial or larger academic centers. So recognize this is the perspective that I'm coming from. And like I said, I'm really going to try to focus on the rationale to some extent, because I think that's an important part for a lot of you. So, of course, most of you are probably currently using RayStation, so you fully understand the benefits of having a single treatment planning system for all of your treatment machines, or at least many of them. So you're very familiar with that. But here I want to talk a little bit about the benefits of adding in the OIS component by adding in RayCare. So that's going to be a focus of this talk. And it really does focus on the simplicity of having a single platform for all of the your OIS and your treatment planning system functions. And that's the main driver here for us. So a little bit about us first. So we are a hospital-owned community cancer center. We're about an hour from Washington, D.C. and Baltimore. We treat roughly 600 patients a day. We have our CyberKnife M6. We have a TrueBeam and a Vital Beam. And for those of you that aren't familiar with the Vital Beam term, it really is essentially a TrueBeam for all intents and purposes, even to the extent that when we have patients, if something happens to the TrueBeam, we can just move them straight over to the Vital Beam and treat them without doing any recalculations or anything like that. It's all on the same the same beam model. So with the CyberKnife, we had been using Precision treatment planning system, the Accuray treatment planning system. And for the True Beam and the Vital Beam, we're using Eclipse. We do also have an HDR, an electronic HDR system, which we don't use very often, is off system, and that uses the brachyvision treatment planning system. And then we also do some prostate seed implants with Veriseed. ARIA is our OIS, and we have Meditech as our hospital EMR. And again, I can speak for our experience. More and more, the hospital EMR is encroaching upon radiation oncology. It used to be that all of our operations were centered in ARIA, but over time, the hospital system is trying to integrate their EMR more and more into each department. So now our physicians and the technical staff are interacting with the EMR more than we used to. So it's very important to have an OIS that's has an ability to connect and work well with the EMR. In terms of staffing, we have 2 radiation oncologists, 2 medical physicists, 1 dosimetrist, and 9 therapists. So this is really all to summarize all of that. We really are very much a Varian site. And then we have the CyberKnife kind of hanging off the end. So that kind of leads to the elephant in the room. We've got this pretty integrated Varian system here. Why are we deciding to transition to RaySearch? So it's a fine question. One of the reasons is because even though we are almost a fully integrated Varian site, we do have CyberKnife, and we intend to keep that, and we want to have the optionality to look at other systems. So if you're not completely a self-contained single vendor site, then you have all of these communication issues. You have the inefficiencies of dealing with multiple systems. One of the inefficiencies, of course, is that when we had the Eclipse and the Precision treatment planning systems, our physicians and our dosimetrist and the other physicist and I were having to operate in 2 treatment planning systems. Obviously, that's could be difficult, both in terms of maintaining our expertise in them, but also just the workflows, having to have a separate workflow when we have a CyberKnife patient and when we have a regular True Beam or a Vital Beam patient. So by having a single platform, having a RayStation and RayCare platform, that will lead some efficiency because all of our patients can be funneled through a common workflow. Cost containment. So this is where I'm going to veer off from where most of these talks go, and that is I'm going to talk about money, because like it or not, this is a reality to the practice of medicine, and probably most especially here in the United States, I would think. And right now, just as a quick primer for those of you that might not be terribly knowledgeable in this area, most of our reimbursement is based on a fee for service. So if we're going to perform certain procedures, then the hospital system gets reimbursed for those procedures. That leads to the effect that the more procedures you do, or the more complex procedures you do, the greater reimbursement. But it appears that we're transitioning to a different reimbursement system in the future, and it's already happening. It's a capitation model, and what that means is that you get paid a certain amount of money to take care of your population. So it's no longer it's a different type of reimbursement system. So in this kind of reimbursement system, a capitation model, you really need to focus on cost containment. So fewer support contracts. Obviously, if you have fewer systems, you have fewer support contracts. that you have to maintain. You have fewer system upgrades, and you have fewer systems you need to purchase. You don't need to purchase multiple treatment planning systems. You don't need to purchase multiple OIS systems. I'm going to come back later to this retaining leverage for capital purchases, because that's something that isn't always recognized up front, but it could be a very important part of cost containment. So I'll come back to that a little bit later. And then getting back to the medicine aspect of all of this, there's the clinical flexibility that you get by going with a system like RayStation and RayCare, because you don't have a whole lot of certainty right now in terms of what's going to happen in the future. So as equipment changes, technological advances, as modalities change, as we switch from longer fractionation schedules to shorter fractionation schedules, as the reimbursement models change, all of these things will have an impact on how we practice. So if you can have a system, an OIS TPS system that is somewhat independent of the actual treatment devices, then that can lead you need or you want, without having to change your entire process. Which is what happens if you have an OIS that is tied with your treatment machine. And one thing that certainly RaySearch has shown is they play well with others. They have agreements and with a number of vendors, and they design their software to operate in another number of vendor environments. So how are we transitioning to RaySearch? So we have a small staff, as you've seen, and RayCare in particular is a maturing product. It's not a finished product, and it's pretty impressive how quickly they've been able to mature the product and add attributes to it. So because we're a small clinic, we need to do this in a stepwise fashion, in a phased fashion, because we don't have a large set of manpower, a lot set of resources to throw at this. And I would make the analogy, we're kind of trying to do a flight system upgrade while we're flying. So we need to maintain our current systems while we integrate these new systems, the RayStation and RayCare. And so it's a phased implementation. And we decided to start with the CyberKnife portion of our practice. It did run kind of parallel to the primary workflows of our department. Most of our patients get treated on the TrueBeam and the VitalBeam through ARIA with Eclipse. So by focusing initially on CyberKnife and that subset of patients, it gave us the ability to do a little bit more focused implementation without having to disrupt our primary department. Gave us a chance to learn the software. Many of you, I'm sure, are already using RayStation. At the time that we decided to start this process, we weren't using RayStation at all. So we've had to learn RayStation first, and then start to learn RayCare and design all of the workflows and everything. So I think a great many of you who are already using RayStation already have quite an advantage. And then we will be moving from Eclipse to RayStation here. We're expecting to do that in the first half of 2024. So all of our TrueBeam and VitalBeam planning will become RayStation. We'll be done with RayStation. And then in the latter half of the calendar year 2024 is when we expect to replace ARIA with RayCare. And part of that is dependent upon the availability of the interface that allows the TrueBeam family of accelerators to communicate with RayCare. So that's the VTI interface I'm referring to there. So not knowing exactly how much knowledge all the listeners have in RayCare. I'm just going to kind of briefly talk a little bit about RayCare to give a base of knowledge here. So it operates very similar to ARIA. It has a lot of the similar capabilities. You can bring in all of your patient information, including demographics and your imaging. You can export billing and documents back to the EMR. It's got an internal PACS system, workflow design, task tracking, similar to CarePath for those of you that are ARIA users. I would imagine that Mosaic has similar capabilities. You do your scheduling, treatment course management, including prescription management, document creation, and then all the different ways that you keep track of all your activities, whether it's patient-centric, opening a patient and looking at kind of the patient story, or whether it's task-centric in terms of, as a physicist, I have these tasks to perform in my day, which encompasses all of the patients. So there's a number of different ways that you can view the information. So in short, RayCare is integrated with RayStation in a similar way that Eclipse is integrated with ARIA, with the benefit that the RayCare RayStation tandem can accommodate a number of different treatment machines, as opposed to the Eclipse ARIA environment, which is a little bit more limited. So I'm just going to walk through some of the main pages that you'll see in RayCare. So kind of the home, the landing page here, will have your list of all the tasks, and then a message board. So there is an interesting aspect of RayCare that I'll talk about a little bit later, where it's kind of like almost an email feature. So it makes communication within RayCare very easy, and it also is linked to the patient as well if the email has to do with a particular patient, which is very nice. You've got your appointments. So this is kind of the landing page, personal landing page. And then if you want to get some information on a particular patient, this is kind of like the patient landing page, if you will. So again, you've got your patient demographics up here, the disease you're treating, the tasks that are associated with that particular patient, and you can view just those tasks that are associated with you, like my tasks associated with this patient, or all of the tasks, so you can kind of see how the whole team is doing and where the patient is in the process. Got your appointments, got your milestones, and this is kind of like a dashboard. This milestones is kind of like a dashboard that allows you to see visually the progress of the patient. And then currently we're not using the treatment course summary or documentation, but that's because in the current version that we have an earlier version of RayCare. We have 6A. In the newest version, there's a lot more integration in terms of the treatment course management between RayCare and RayStation. So once we get that new upgrade, that 2024A, then we'll begin to bring in the treatment course management aspects in our practice. You've got your calendars, just like you would with your ARIA or with your Mosaic. Again, this is our current version of RayCare, but the newer version, I got a sneak peek at it, and it's much improved. There's a lot more granularity to it. There's drag and drop. There's color coding, more so than what's in this current version. So RayCare is rapidly evolving, so we're excited to get that next version. There's all of your whiteboards. For those of you that are my vintage, let's say, you're used to seeing a whiteboard and a grease pencil or something like that. That's how we all started, and that's how we would keep track of where each patient was and what activities needed to be done. So, and there's a number of different whiteboards you can have: the planning whiteboard, QA, charge review. So those of you that are going to be having to review all of these patient charges. You can have a whiteboard for that. So there's a number of different whiteboards that are available, and you can kind of customize the way you want them to appear. So again, all of this is really just to show or to demonstrate that that RayCare is going to drive our process, is going to drive all of our activities in our clinic. And this is just an example of all of the different activities associated with bringing a patient from simulation, or registration rather, through simulation, through treatment planning, and delivery. So each of these tasks has a series of subtasks associated with them, and you can keep track of them. And as time has gone on, RayCare and RayStation are becoming more and more integrated, which is a wonderful thing to see. So I did want to talk a little bit about the couple of my favorite parts of RayCare, and one is this messaging area. So if I'm in the middle of a task, when I'm getting ready to complete my task, I can add a comment, and maybe this is a QA task, and the comment would be providing information about what the QA results were. So then those will show up on this patient landing page, if you will. So anyone that comes in, the patient can see it. And that would be akin to like ARIA journal, if you will, except for this is right on this front page. You don't have to go searching for it. But I think the even better thing is that you can generate a message, kind of like an email, that doesn't have to be associated with that patient, to alert staff, individuals of really any kind of information you need to provide. But if it is associated with the patient, then it also goes into the patient's records as well. So it's a secure, integrated messaging system. And if I create an email here, let's say, then if I'm sending it to the radiation oncologist, the radiation oncologist will see it in their messaging area, their own personal messaging area, but it will also be housed within that particular patient as well. So it's just a nice way to both communicate with other staff and document within the patient's chart what those communications are. It's really a very simple, straightforward method for communication, and yeah, it's very, very, very nice. So let's talk a little bit about some of the limitations that we've seen as we've gone from Precision to RayStation. So we really haven't run into very many limitations, honestly. We have all of the delivery modalities that are supported, the MLC, Iris, and fixed cone. We have all the tracking modalities. We have Monte Carlo. We have collapsed cone supporting as well. Below 12.5 millimeter iris, you need to use the Monte Carlo. You can have fallback planning from CyberKnife to TrueBeam. So if our CyberKnife goes offline for an extended period of time, then we can have a TrueBeam plan either generated or generate one from that CyberKnife plan. So we'll try to mimic the CyberKnife plan as best it can. Currently, you can't go the other direction, though. You can't take a TrueBeam and create it into a CyberKnife plan, at least not yet. You also can't use multi-criteria optimization in CyberKnife planning. And I don't know whether that's something on the drawing board for the future, but currently you can't. And like any system or evolving system, there's opportunities for improvement. And again, I will stress that this is for the current versions of RayCare and RayStation that we're using. So one of the things that we've found is the CyberKnife delivery time, not the calculation time, but the delivery time is roughly 10 to 20% longer than it is with our precision-based plans. Now, we've only been planning for a few months with RayStation, so we're still learning. But we have seen slightly longer times. Granted, we've discussed this with RaySearch, and they're investigating with us why that might be, but they've also made some improvements in their algorithms. So during the calculation process, it will do a better job of minimizing the number of nodes, minimizing the number of beams, which will translate into shorter delivery times. So we're very interested to get this next version of the planning system, so we can see that, and then do another comparison. There's no CyberKnife image review and approval function within RayTreat, and and to be honest, that's a little nitpicky on my part, because even within Accuray's own system, there's not a clean way to do this image review and approval. They have to send the images off to like another application. So it would be great to have something like that within RayTreat, but that's kind of like an icing on a cake thing. The unified prescription space, so that is something that's already been addressed with this new version. So the version we're using, the prescription pace is kind of decoupled between RayCare and RayStation, but in this new version, the 2024A, they're much more integrated. So we look forward to using the prescription space in the new one. Switching between patients. So right now, when you're in RayCare, whenever you need to go from patient to patient, you need to go back to the patient tab. So if I'm reviewing billing, let's say, in Mrs. Jones, if I want to then review billing for Mr. Thompson, I have to go back to the patient space, pick the patient, and then go back to the billing area. Now, one way around this is to make more use of the whiteboard for billing, and that's something that we're still exploring, because again, we're still pretty early in this process, so we're still learning how to use RayCare, well. And then the very last point here, again, is something that RaySearch has done a great job already in the newest version. From what I've seen, the calendar is much more useful and much more similar to what we're used to in ARIA. So they've made a lot of progress there. So now let's actually move on to the CyberKnife portion of our talk. And so when we've got a CyberKnife patient in RayStation, the upstream process is bringing in your images, doing your registrations, doing your contouring. All of that is the same, whether you're going to create a CyberKnife plan or whether you're making just a plan for any other machine. So that's a benefit, that you have all those same processes. But then when you do get to creating the plan, you select CyberKnife, you select your motion technique. Again, all of your motion techniques are available here, just as they are with precision or multi-plan. You select your collimation, you select your node set, you select your align center. And for those of you that do have CyberKnife, you'll know what I'm talking about. And then you're pretty much off to the races in terms of doing your optimization. Is very similar to what you do for all of your other creating plans for all of your other machines. There are a couple of attributes that you do need to select for CyberKnife in particular. Like you put in a number of beams, number of nodes. There's a couple of things that you can put into the system that will help you to make the delivery more efficient, or if need be, more complex. So this is where I was talking about how the delivery can sometimes be a little bit longer with the RayStation plan. Part of this is because we are still learning what the optimal numbers are to put into those settings. And with the new version of RayStation, my understanding is that it's going to help a lot, because it's going to put forth a lot of effort trying to minimize the number of nodes, minimize the number of beams, instead of just using the initial number that we put in. So that will make the delivery more efficient. So now we're going to talk about kind of the whole flow of a patient, one of our CyberKnife patients. So we bring all of the imaging in, the DICOM images in to RayCare. We bring all of the demographics, insurance information, all that in from our EMR. All of that drops into RayCare. Then, depending on what the what we're treating, what site we're treating, we'll have a different set of activities, all of our tasks, and we'll step through each one of those tasks. Each time a task comes up, it will be tasked to the appropriate person, and that person will select that task, and it'll take them to the appropriate screen to complete it. Once they complete it, it'll kind of bring up the next task in the queue, and it'll drive the users back and forth between RayCare and RayStation to do those tasks. And you can also access those same task lists within RayStation as well. So again, it's kind of like a seamless integration. It'll drive you through the whole process, and it'll take you where you need to go. So after you have a completed treatment plan, an approved treatment plan in RayStation, you send it through the IDMS, which is Accuray's CyberKnife's information management system, and then it gets held up at the Ray Treat Station. So the Ray Treat Station is the RaySearch component that will communicate with the CyberKnife. So when our patient comes in, they'll check into RayCare, then we'll open that patient's session in RayTreat, and that will then allow that plan to go over to CyberKnife. We'll treat the patient in CyberKnife. Once the plan is delivered, the records will be sent back to IDMS to complete Accuray's kind of internal loop, and it'll also be sent back to the RayTreat station, and then on to RayCare, where that information will be housed. And you can do your billing in RayCare and generate any documents that you might want to go over to your EMR. Of course, sometimes things don't go incredibly smoothly. Once in a while, you do have machine problems. So if you have a partial treatment in CyberKnife, then what it'll do is it'll create the remaining treatment. It'll send it back to RayTreat, which will prompt you to reschedule the patient. And then it will make that completion plan available back in RayTreat, and you can finish off your treatment. And this happens on occasion. So we've gone through this a few times, and it's a pretty smooth process. So one of the things that I'm trying to do with this talk is really to provide food for thought for how you might want to think about reorganizing the way you design your practice to run. So when I first started here at Frederik, we were a one vendor system, solo vendor, treatment planning system, OIS, delivery system. We had ARIA, we had Eclipse, and we had Clinax back in the day. And very well integrated, very simple, very straightforward. There's a couple of problems though. One is you're married to that vendor, so they better have all the machines that you want, because you really can't stray too much from that, and to retain that efficiency. But then there's also the issue of cost. And if you remember a number of slides ago, I had brought up the fact that in cost containment, losing your pricing leverage can be important. So unlike going to the grocery store and buying a dozen eggs, where everybody pays the same price, when you're buying this kind of equipment, the price that's set is really going to be tied to the perceived need of the customer. How much is the customer willing to pay for that product? So when you place yourself in a position where you're so invested in a single vendor, there's less of a impetus for them to be really aggressive with the pricing of their systems, because they know it's going to be very difficult for you to stray and go in a different system. It's going to be a lot of work. It's going to be a lot of cost, because you would have to buy a new OIS or a new TPS. So that's something to keep in mind. That can have a large cost impact. And please don't think I am throwing stones at any particular vendor or radiation oncology vendors in general. This is just business. This is how businesses work. Commercial businesses need to make money. They're profit driven to some extent, of course. So this is just the way any business is going to work. They're going to price the product to get their maximum return. And when you're in a captured system like a solar vendor system, then they recognize that it's going to be very difficult for you to leave. So how can you adjust that? How can you impact that? Well, you go with multiple vendors. Now all of a sudden you've got price competition because vendor one knows that they need to do a good job of making their pricing competitive with vendor two and vendor three. However, that brings out a lot of complexity. You've got all these treatment planning systems, not necessarily designed to work with the OIS that you have, and then the OIS, while it might work great with your primary delivery system, might work less well with the other delivery systems. So it just adds a lot of complexity and it adds a lot of duplication of costs. So we can fix that. We get RayStation, right? And that's an excellent start because now you don't have the duplication in treatment planning systems, that cost. And it's also more simple because you have a single planning system. However, you still have full IOSs to deliver or to deal with, or you've got a situation where your OIS that you do have, ARIA, Mosaic, whatever, isn't designed really to work with RayStation. And then that OIS again is only designed to work with one delivery system and not the others. So you still have some issues there. So that's where we've decided to move on to a single planning OIS platform, because that provides us with the opportunity for cost savings, for efficiencies, and it also allows us to kind of break away from the or regain some of that pricing leverage over the delivery systems. And as those of you who have purchased these systems know, the delivery systems are expensive. They cost a lot of money. So be able to retain some pricing leverage is very beneficial from a system point of view. So, and I also wanted to mention that I know that there's a lot of folks that are probably watching this that are from larger academic centers. Hopefully there's a few community cancer centers as well. This does take a lot of time and effort, but we're trying to demonstrate that it can be done in a community cancer setting as well. We don't have the large staff and residents and whatnot to help with some of this, designing this system and testing it. So it falls upon just a few of us, but it is something that we are able to do, especially when we are able to phase in the approach. So if you're a small community cancer center, it's a doable thing. If this is something that after taking some time to digest, this is an area that you would like to move forward on, or you would like to at least have other discussions in your facility about, there's a couple things you might want to think about. One is you need to bring administration in. Obviously, there's going to be a cost associated with a new system. So you need to show them how, by making this transition, you're going to be reducing operating costs, and again, talk to them about increasing your capital pricing leverage on those large delivery systems. You need to talk to your physicians, obviously. There's a lot of the simplicity that's associated with a single system. They're not having to learn multiple planning systems. They're not having to learn multiple OISs. They're not having to deal with transferring data from one system to another. So it really simplifies their life. So much so that I put the same point in twice. When it comes to staff, your staff, they really just want to get the job done efficiently and effectively. So again, by having a single platform, planning OIS platform, it simplifies all their tasks they have. And then your patient advocates, certainly there can be some safety issues associated with all these handoffs between systems. So if you have a more comprehensive system, fewer handoffs, when you have updates to one system or another system, when they're all done within the same vendor, that can increase your safety margin. And then you retain the ability to really pick the machines that you want. And that goes back to that previous slide where I was saying that we really don't know where radiation oncology is going to go. We know where it is in the next couple of years. We have a good idea of where it's going, but who knows what new advances are coming, whether it's technological or some other thing that would impact which machines we might want to get. By going with a vendor neutral, a treatment machine vendor neutral OAS and planning system, you're able to retain that flexibility to really pick whichever machines best suit you and best suit your environment. So as with any adventure, any quest, there are some lessons that we've learned along the way. And first one is we do need to embrace duplication while you're transitioning. And again, because we're a smaller system, we need to be able to implement a change, but recognize that if we find something that isn't functioning the way we need it to, we can still treat patients. We can still keep our systems going as we address whatever problems we run into. We were fortunate with having the CyberKnife being somewhat parallel to the majority of our workflows, that we had a subset where we could do this implementation first, learn our lessons, learn how best to configure RayCare, for instance, before applying it to our larger patient population. This is a very important one, and this is one that I'll give a shout out to a couple of RaySearch employees, Mo and Misty. They were very helpful in this part, because the kind of the knee-jerk reaction that a lot of people have when they're changing systems is they want to say, okay, the new system, how do we make it do what the old system does? Because that's what we're used to doing, and that's the way our workflows were designed. But you need to take a step back and recognize that different software is going to have different advantages. So you need to take advantage of the new software. You may need to modify one of your processes to take advantage of the new software. And in the end, you end up with a better process. So don't just try to shoehorn your old processes into your new software. Think about what you're really trying to accomplish, and if there's a better way to do it with that new software. Data transmission. That was probably the Achilles heel, and in terms of the implementation so far, it could be very difficult when you've got multiple vendors working together in a very early integration like this. We were the first system in the U.S., first hospital system in the U.S. to use CyberKnife with RayCare, RayStation, RayTreat. So being first through the door, it could be difficult sometimes, and a number of those difficulties had to do with data transmission, whether it's different drivers that needed to be updated, and it certainly didn't help that I don't have a great deal of knowledge in that area. So you're going to lean heavily on your IT folks during that process. So be sure to get them in early, get them here often, and take full advantage of the testing systems that you have before implementing it into the actual clinical environment. And then probably one of my favorite quotes of all time is, "Plans are useless, but planning is indispensable." So of course, we had all sorts of plans the way we expected the whole process to go, and it did go reasonably well. But part of the reason it went well to this point, I think, is because we did plan out in detail, and as soon as you hit that first barrier, you kind of had a map for how to work around it. So it's important to make detailed plans, even though you know those plans aren't going to go the way you expect. So that's kind of an overall lesson that I had there. And I did want to thank certainly Shay. Dr. Shay is the other physicist here, and he's really the expert in CyberKnife. So he's taken on a large load of this project, and our therapist Wayne Flowers has really embraced RayCare, and then there's some excellent RaySearch personnel and Accuray personnel that have helped us in the process. And I'll be looking forward to adding Varian down here once we get to the point where we're going to transition ARIA to RayCare. So I think that's about all I have. I'm happy to take on any questions. Oh, I don't hear you, Dana.
I just saw that. Great. Thank you so much, Dustin. Great presentation. If anyone does have questions, please use the Q&A tool at the bottom of your screen and ask, and we'll do our best to answer them. We do have a couple that have come in, and maybe a couple things to note while you grab a sip of coffee. You know, we've done some nomenclature, kind of naming convention changing throughout RayStation and RayCare both. And so you mentioned 6A is the version that was released and what you're using. Then we've gone to 2023 in the year of 2023 to kind of match. We synced up RayStation and RayCare. And so 2024 is the latest RayStation release that has been submitted to the FDA. And now RayCare will also have a 2024A version that will be released this coming March. It will require an FDA submission, but then we'll be back synced again with both of those versions in the year we release them, which is great. You mentioned fallback planning, which is RayStation, beautiful feature for people that have multi-vendor environments. Do you create an automatic plan at the end of every approval for when you do the CyberKnife plan? So they're just sitting there contingently, or do you wait until the machine goes down? How do you utilize that function?
Well, right now we're not utilizing it because we'll bring that in once we get the interface between RayCare and TrueBeam, the VTI interface that Varian and RaySearch are working on. Once that's available, and then once we start to do our TrueBeam planning in RayStation as well. Once we do that, then we really need to have that discussion to decide if we're going to make a fallback plan for each and every patient, or if we're going to just generate those as needed. Yeah, and I think
I'm a proponent that they are as just there. It's an automation. You finish and approve, and you say, "Hey, make the plan," and then it sits there until which point you need it. So hopefully that's where you get to.
yeah, it certainly sounds like that's the most efficient way to go.
Right, right. So then there's not this panic if a machine does go down. So another question. You said RayCare is integrated with RayStation as Eclipse is integrated with ARIA. What do you consider RaySearch's key strengths in that context?
Well, the primary strength, I'll mention a couple of things. One is just the fact that it's a lot limited to just a couple of treatment devices, as ARIA and Eclipse would be. It can accommodate all of a number of treatment devices. And that's really the main reason that we went down this path in the beginning, because we wanted all of our treatment machines now and in the future to be really all under one umbrella, one OIS and RTP umbrella. So that's the main crux behind why we were moving forward with this project. But more specifically, I like the messaging aspects within RayCare. The fact that I think communication between the therapists, physics, dosimetry, and the physicians is much more attractive. I think it'll be more efficient with RayCare than what we're currently using. So that kind of integration where we can communicate more effectively, I think, is one of the primary things I like about RayCare in concert with RayStation.
Awesome. You also said in your presentation that RayCare drives the user to the proper location to carry out a task. Do you need to, maybe can you clarify, do you need to open the patient and navigate to the right step in the workflow when you move from RayCare to RayStation?
No. So in that one view, like the the RayCare view where it shows what tasks I have to do. I will just click on that task. It will take me to that patient in the window that I need to be in to complete that task. So it does it automatically. One click, it takes me where I need to be in the patient I need to be in to accomplish the task. And then once I'm done, a number of those tasks will self-complete. It will know that I've completed my task, and it'll automatically queue up the next task, either for myself or somebody else.
We actually had someone who said, sorry, I missed the first few minutes. Can you give us some idea of the size of Frederik's health operations? Can you reiterate that for us?
Sure. So we've got one CyberKnife and 2 conventional Linacs, a true beam and a vital beam. We treat roughly 600 patients a year. So we're looking at 50 to 60 patients a day. And we're kind of at the intersection of suburbia and rural Maryland. So yeah, we get a decent number of patients, but we do have access to tertiary facilities for like pediatric patients and very complex cases with University of Maryland and Johns Hopkins and Georgetown and the like. So we're actually in a very comfortable position. I think where we are. But yeah, that's about the size of it. It's 50 to 60 patients a day on 3 machines.
Beautiful. I think with that, we will go ahead and wrap up this webinar. I'm really appreciative of your time, Dustin, your expertise. You are a great advocate for these products and for the vision that we see. So thank you for putting this together, for your time, and for everyone out there who also took the time to watch this webinar. We do want to remind you of one more coming next week. It's, I think, the same time on Thursday. Dustin, do you have one more slide forward that talks about that webinar? I think you can still, there it is. You can still sign up for it on the RaySearch Laboratories website. Please join us, tell your friends about that. And I think that you see the powerful vision that we've had with RayStation and RayCare, and it's so wonderful to see it in action at your clinic, Dustin. So again, thank you to everyone for watching.